And Kathleen is going to handle the extremely difficult topic about what is the decision process for deciding treatment therapy when you get a diagnosis of multiple sclerosis.
All right, very good. Can everyone hear me? No? How's that? Is that better? Okay, wait a minute now. Let's put it up here. Does that make it any better or worse? Better? Okay, I'm probably going to turn this way a few more times than this way, so this will probably be good. Thank you very much. It's a pleasure to be here. I'm sorry, having heard some of the references to yesterday, that I wasn't able to be here. But through the magical experience of air travel these days, I was traveling until about 9 o'clock last night from the East Coast. Always a lot of fun to get in a plane, to push back and think you're going to leave on time. It's the big airline tease, and then sit there as a captive. But anyway, that's how it goes. So anyway, I have been asked to speak to you today about treatment for new diagnosis of multiple sclerosis. And I put this in here just because it was a lovely day and I think a lovely picture. It's from Cooperstown, New York. Has anyone ever been to Cooperstown, New York? It's beautiful. So every summer I go up there. My son works there, and I think, oh, what a lovely place to live. It's a little kind of Currier and Ives kind of a place, and the weather's always gorgeous when I'm there. So I asked, what's the weather like the rest of the year? And they said, well, winter starts about September 15th, and it goes to about Memorial Day. I said, oh, perhaps I'll stay where I am and just live with this beautiful image. So when we talk about multiple sclerosis, we're talking about the immune system dysfunction. And I've heard the analogy now of the cats on the wires, and certainly makes a lot of sense. And the cats on the wires here are causing damage in the brain as well as the spinal cord. And we know that that damage is both inflammatory and degenerative. And there is not only demyelination, or the loss of that coating on the nerves, but there's also damage to the nerve fiber that lies beneath the myelin. And we know that what that translates into for people that have this disease is that they have relapses of symptoms, and then they have progression of symptoms over time. So if we looked, and you may have seen something similar to this yesterday, but if we looked at the normal nerve fiber in the central nervous system, it would look something like this cartoon, where you have lots of myelin around nerve fibers. And if you demyelinate, if you cause inflammation that damages the myelin, then you'll get this appearance where the axon underneath the nerve fiber is still intact, but there has been loss of that coating that aids in the how fast or how rapidly nerve transmission takes place. So I like, this is the old phone cord or wire kind of analogy, that even when this damage has occurred, under ideal circumstances, nerve transmission continues to occur. But if you change those circumstances, you may have periods of time where nerve transmission isn't so good. And we know that there can also be, in addition to that damage to the myelin, there can also be damage and complete loss of that axon underneath. So that if you have that, of course, your nerve transmission is going to cease beyond that point. So in MS, we know that many people begin with symptoms. They have those symptoms for a period of time, and then they resolve to a certain point, perhaps 100%. So what's happening if this is, in fact, the pathology of the disease? So a lot of things. You've heard that there is some innate repair mechanisms that exist within our bodies so that there is some resolution. There's certainly a resolution of inflammation. We know that there's some remyelination that takes place and some reorganization within the central nervous system so that other areas of the central nervous system get recruited to take over function or to add to another area with function so that function can be restored. But we know that over time, these reparative mechanisms and the ability of the brain to reorganize don't last forever. So that's when we're worried that we're going to get some damage that might in fact be permanent. So this is just a lot of words to say that the immune system is the culprit here. And one of the things that happens is that the immune system loses that ability to distinguish self from non-self. In its confusion, and particularly with MS, that misguided immune system is directed at certain types of cells within the central nervous system. In the case of MS, that would be those that are involved with myelin and the axon. Okay? So that's when these things start to happen, that's when we see signs and you experience symptoms. So if you looked at what that might appear to be, we would have an MRI lesion, and this would be an enhanced lesion. So how many people have had MRIs? How many people have gotten gadolinium during that MRI? So in giving gadolinium, if there's active lesions, active inflammation, they show up bright, like someone put a flashlight on them. But if we looked at what that might be pathologically, we would see the blood vessel, and this area would be a lesion, and all these little black dots would actually be cells of the immune system that got through this blood vessel wall and into the brain tissue itself, where that inflammation and that damage is going to be taking place. So why do I tell you all these things? Because it's that immune system dysfunction in multiple sclerosis that we're looking at when we're looking at our treatments. How can we modify this immune system in order to still have an intact immune system that works for us in terms of infections, but is altered somewhat so that this damage isn't taking place? And we have a vast array of armamentarium. We can hit MS with nuclear warfare, which would be with immunosuppression, and we can hit it with modulation, not even machine gun, more like taking the teeth out of the cat. Okay, so it's still there, and by and large still works, but when it comes to multiple sclerosis and that kind of damage, there's not as much of it going on. However, there's one major problem with the current therapies that we have for multiple sclerosis. Aside from the fact that they're not a cure, which is a major obstacle, but what's the other problem for those of you who have had treatments for multiple sclerosis? What don't you like about them? Let's see, yeah, they're all injectable. Okay, so you'll hear about drugs that are in the research pipeline that aren't injectable, that hopefully will be as effective, if not more effective, than the treatments we already have. So our treatments are interferons, Rebif, Betaseron, and Avonex, and non-interferon in Copaxone, a monoclonal antibody in Tysabre, and immunosuppressant in Novantrone. So various ways to get at the problem. So what about these? What are some facts about these disease-modifying therapies? Well, we know that they work best when they're started early, which is very frustrating to people who have had multiple sclerosis for a period of time and didn't have the advantage of being on the therapies early in their disease. We also know that these therapies are only useful if people can stay on them for a long period of time. They're long-term therapies. This is probably the toughest part about being on a therapy for multiple sclerosis. How many of you have ever been on an antibiotic for 10 days, 3 times a day for 10 days? How many people had trouble remembering that middle dose of the day? Okay. How many people, be honest, didn't finish all 10 days of their drug? Okay, so a few more. So, and you say, well, come on, this is multiple sclerosis. This is vastly different than taking an antibiotic for an infection. But really what it is, it's human nature. And it's very difficult to adhere to anything, even when it's important for the long haul. So this becomes a major problem when we start therapies to be able to be on them a long time. In terms of the drugs themselves, there's a little bit of dose effect that we've seen, at least over the short term, when we look at once-a-week interferon versus more frequent interferon. We know that there was similar efficacy in certain trials looking at the non-interferon Copaxone and interferons. We know that even the Academy of Neurology got involved by saying everybody ought to be on one of these drugs, and they are effective. And the National MS Society did the same thing when they got involved and said these therapies work, everybody ought to be on them, and insurers, you should be covering all of them for everyone. That message hasn't quite gotten through, but we're still working on it. And even though these therapies have been around a long time, in the world of pharmaceuticals, these are old drugs now, with the first one coming along in 1993 and going through the early part of this century. But they're considered pretty, other than Tysabri, they're considered older therapies. And so they continue to be studied. Can they be used in something else? Can they be used in a little bit of a different indication? And some of that information has come out more recently that perhaps they're useful in the first event that someone has or a clinically isolated syndrome. So not MS, but the step before you would call someone multiple sclerosis. And can you use them in more progressive forms of the disease? And yes, given certain characteristics of that type of progression, yes, you could use at least the more frequently given interferons in a more progressive type of disease. Is there anyone in here on any of these therapies? Okay, so a few of you. All right. And this, again, is the National MS Society statement that basically said you should be on one of these drugs if you have an established relapsing diagnosis of multiple sclerosis, and you should stay on them unless the side effects are completely intolerable, you continue to have MS attacks or worsening, or what everyone wants, improved agents come along, and you have to switch because there's something better. So our feeling is that when people hear all this and still are having difficulty starting on a therapy, we believe as providers that perhaps some people are still living with their head in the sand. Although it's important for us to realize as providers that people have to be ready to begin this therapy. It's very difficult. You see someone's disease signs, their symptoms, their pathology on the MRI, and you're very keen to start them on therapy that day if you could. But that person has to be ready to be on that therapy. And that's a big part of choosing a therapy and starting, is making sure someone is on board with it. Ideally, the person with the disease is on board with the therapy as well as their family, because that becomes then their support system to help them with the long-term adherence, which I've already said is so critically important in the treatment of this disease. So what can these therapies all do? So they're all very powerful anti-inflammatory drugs, and they can, to some extent, delay the accumulation of disability. At least the part of disability or the part of progression that's related to inflammation can be modified by these drugs. We see fewer new lesions or fewer accumulation of lesions on the MRI, and we see fewer enhancing lesions. So that flashlight effect, when the blood-brain barrier, the blood vessel wall has been kind of breached, and those immune system cells get into the central nervous system to cause inflammation, these therapies can reduce some of that from happening so that there's less inflammatory changes that we see reflected in an MRI. Unfortunately, the current therapies are not a cure, and they can't alleviate symptoms. And that's a big part of the educational process when we want to put someone on one of these drugs, because one of the first questions is, because often someone is either having symptoms or they've just had symptoms. They may be in a recovery period. And they'll say, when are my symptoms going to go away? Well, unfortunately, they're not directed at what's gone on in the central nervous system. What's gone on in the central nervous system has gone on. What these drugs are directed towards are the changes, the misguided immune system in multiple sclerosis. They cannot stop disability, but they can delay some of that disability. In some people, they'll delay it for a long, long time. In others, not so long. They cannot repair the damage. Again, these are working on the immune system, okay? And they, to this point, don't have much of a role in regenerating myelin, which we'd all like to see. So the interferons. There's less activation of those immune system cells with interferons, and they have some blocking ability at the level of the blood vessel, so that immune system cells are less likely to be able to get into the central nervous system. So beta seron being first, 1993. And you're going to see kind of a theme with this reduction in relapses. How many relapses did somebody have in a year, and could you reduce that by a certain amount? So they could reduce it by about a third, cut severe relapses in half. Now, these are averages, so there are people who do much better, and there are people who don't do it quite as well. Effect on the MRI with fewer lesion accumulation, and then in subsequent studies, actually after the drug was approved, there was a look at how this drug worked against those inflammatory lesions, and it was also very effective there. This is just what the FDA says the drug is indicated for, which becomes very important to our insurance companies. You know, if we want to go outside of the labeling, we run into some difficulty with the insurance companies. So less effective in more progressive forms of the disease, and of course it's an every other day injection. Avonex has a much longer indication. It took up the entire column because it was studied in clinically isolated syndrome, that very, very first attack, and found to have some efficacy there. So that was placed in the labeling. But again, in those patients who completed 2 years of the study, about a 30% reduction in relapses, delayed progression of disability, positive effect on the MRI, not effective in secondary progressive, and it's a weekly injection, which a lot of people have been very interested in over the years. If you got to take an injection, perhaps once a week would be better than these multiple times per week. Rebif was the last interferon that was approved in the United States. It was approved elsewhere. It structurally is identical to Avonex, but it's given more frequently. It's given 3 times a week. And there's the magic number again of about 30%, with an effect on disability and the delay of disability, with an effect on the MRI. Its indication, relapsing forms of MS, not as effective in secondary progressive MS, and 3 times a week. So a Monday, Wednesday, Friday kind of a thing. Copaxone, the non-interferon, works a little bit differently. The end result becomes the same. Reducing inflammation, so reducing relapses, having some effect on progression, having some effect on the MRI. It was felt for a long, long time that Copaxone wasn't as effective as the interferons. It didn't work as fast. It was okay, but it took a long time to get going. And that was the basis of 2 very large clinical trials that were actually funded by the interferon companies, only to find out that, in fact, Copaxone in those particular studies worked about the same, worked equally. Big drawback with it is that it is, in fact, a daily subcutaneous injection. And the folks at Teva got on the whole oral bandwagon very early and made an oral form and tested it, but sadly it did not turn out that it was an effective therapy. So we were very excited to think that we could have an oral therapy, but in fact it wound up not being effective. Tysabri. Tysabri is a monoclonal antibody. It's given intravenously once a month. It's kind of the new kid on the block. In its study, it reduced relapses by about 2/3. So as you can imagine, there was a tremendous amount of attention given to the approval of this drug because it was much better, at least based on this particular clinical trial, it was much better than what we already had. And it was thought that perhaps this drug would take MS by storm and everyone would be on Tysabri because it was much more effective. However, there's always a but somewhere in here, right? So the but was that a few people that were in the clinical trial developed a rare brain infection called PML, which is a very bad thing. It's not often seen in an immune intact individual, but in an immune compromised person, you can see this in AIDS, in severe patients who have had immunosuppression, and it was seen and thought to be related to the administration of Tysabri. It came off the market, came back on the market with lots of recommendations and a risk management program. And to date, there's been over 30,000 people exposed to the drug, And fortunately, after 2 years back on the market, no one has developed PML. Many believe it still might happen, but certainly our initial fears have been quelled to some extent. But still in all, people generally use Tysabri second line. If someone doesn't respond to a less toxic medication or less potential toxicity, then perhaps Tysabri would be the next choice. I do believe, though, that there are a number of providers that, given a person who maybe has a more aggressive course to their disease early, this might be considered an earlier treatment option than it was when it was first re-released. Finally, Novantrone, and this actually is not the logo, but I put one together. I thought it looked pretty good. It's actually had gone generic, and the folks at EMD Serono are not as involved with it as they, of course, were before it was generic, right? So Novantrone's actually indicated for people that have more progressive MS. Either their relapsing MS is worsening, or they are progressing in their disease. So this is a chemotherapy drug. It's very effective, although it was really what led to its approval was a very, very small trial. But it was found to be effective. Its big but is that it is chemotherapy, and it does have toxicities associated with it. And probably the major toxicity that's associated with it is cardiac damage. It can damage the heart muscle. So, and it's a drug that will have a cumulative effect. So you can only have so many doses in your lifetime, and even if you haven't had any cardiac problems, that's it. You can't have any more of this drug. So it's not used a whole lot, but it has its place in people who are having progression of their disease and they're worsening relatively rapidly. This can be a very, very effective therapy. It's given every 3 months up to a lifetime maximum dose. So side effects, I thought I'd put them on a grid. All the drugs and the major side effects that occur. So we'll start with Copaxone, the everyday medication. Side effects, injection site reactions, and a post-injection reaction, which is somewhat curious. People feel like they're having a heart attack. That's swell. Most people take their injection at night, so who are they going to call, right? Well, now there are phone numbers that people can call if they're having difficulty. It's generally a self-limiting reaction that people have. It has not been found to be a dangerous reaction, just a bit scary to say the least. The interferons have a bit more in the way of side effects, but again, very manageable. Injection site reactions, because all of these drugs are given subcutaneously, like someone with diabetes would take their insulin. Flu-like symptoms with interferons. Interferons occur naturally in our bodies. They're involved with our response to infection. They have part of their role is to raise body temperature. When we give superhuman doses of interferons, you can get a little spike in your body temperature. In people with neurological disease, exposure to heat generally doesn't make them feel so good. So temporarily, these can make people feel poorly. There is some thought that these drugs are related to depression, and you have to monitor some laboratory tests. Tysabri, we talked about not exactly being first line for most people. We do have to monitor labs and watch for infection, with the big one, of course, being this brain infection known as PML. And Novantrone, lots of lab tests, the cardiac damage I mentioned, and the risk of infection because it is, in fact, an immunosuppressant. Okay, so now let's get down to really what we're supposed to talk about. Where do you start? What's the good, better, best? Well, it's an interesting phenomenon in multiple sclerosis care to me. Does anyone in here have high blood pressure? Does anyone have high cholesterol or anything that they're being given a drug for on a regular basis? Okay. So when you were diagnosed with this other problem, did your physician, nurse practitioner say to you, listen, for your hypertension, there are 65 different medications. I'm going to give you literature on all of them, and I want you to take it home, and I want you to read it, and then let me know which one you'd like to be on. This doesn't happen, right? Listen, I want you to be on this drug, lisinopril. And that's what you do. Okay, fine. And here's the literature. But this phenomenon occurs in multiple sclerosis, where we give people these kits oftentimes and say, here you go, take these 4 kits home on Avonex, Betaseron, Copaxone, and take them on home, take a look at them, and let me know which one you'd want to be on. I think that people, I'm a patient too, not with multiple sclerosis, but we're at one time in our life or another, we're all a patient for some reason, correct? I like being part of the decision-making process. But even as a provider myself, I'm not so sure, if it's not my area of specialty, that I want to be the one that says, okay, this is the one I think is best. What do I know? So how many people in here want sole decision-making on the therapies that they're on? How many people want the doctor or the nurse practitioner to make the decision all on his or her own? How many people want that to be collaborative? Of course. I think what happened in multiple sclerosis might be the fact that these drugs are not cures, and for very many people, they're felt to be very similar in their efficacy. Since they're injectable and they have side effects, more decision-making capability was given to the person who's going to be on the opposite end of that needle. So I think that's where it happened. I think, on the other hand, that we probably should not do this. What about similarities and differences for this good, better, best? How do we think this through? Are they all the same? Do they have differences? Well, there have been a couple head-to-head trials. Head-to-head, high-dose interferon with the once-a-week interferons, both of them, both Betaseron and Rebif versus Avonex. And over the short term, it appeared as though the more frequently given interferons were a little bit better. In terms of neutralizing antibodies, not something I mentioned, but you can develop antibodies to these drugs. You develop less antibodies with the weekly medication, more antibodies with the frequently given. This is becoming confusing as I say it, because there's all these little nuances that you're trying to keep in your head when you're making this decision. What about glutiramer? It was found more recently to be very similar in efficacy to the interferons. Okay. Some people believe Copaxone doesn't have side effects. That's not true. It has side effects. It has skin reaction side effects that can be really very upsetting to people. It can cause a kind of an indentation in the skin over time that doesn't go away. Natalizumab, found to have a great response, very effective therapy, with that big but. So is it something that we're going to jump in and use on somebody right away? Or are we going to go with one of these other therapies? Then, part of this decision-making doesn't have anything to do with the drug itself. It has to do with the person who's going to be injecting the medication. I can tell you for a fact, there has never been one person that has come into the office and said, I am so happy there's a shot because I have waited all my life to take a shot every day or every other day. It just is never going to happen. So this is a big problem because in starting someone on therapy, we want to be able to be as sure as we can that it's a therapy someone can stay on. Okay? A former Surgeon General said, the best drug in the world is useless if you can't take it. Same thing here. So a lot of it is getting to know who's going to be taking this injection and are they going to be able to do it? What's their lifestyle? Because the drugs have certain similarities in their efficacy, you want to make sure that you're giving the best drug for that individual. So for you, perhaps it's Rebif. For you, perhaps it's Copaxone, and so on. So the diagnosis is made, which can be obviously very devastating for people to contemplate now having a lifetime illness. In the same breath, because as you recall earlier, I said that these drugs work best when started early. So now you're saying you have multiple sclerosis, I want you to be on a shot. That's an awful lot. Pick one or the other, okay? And maybe allow a little time to go by before you jump into the injectable. There's another very excellent clinician in multiple sclerosis who said once that MS is not a sprint, it's a marathon. So in our efforts to start early, keep in mind that this marathon lasts the rest of someone's life. And that if a week or two goes by, you're still early in the disease process, and you need to allow someone to integrate this diagnosis into their life before you launch into therapy. And in doing so, you stand the best chance of having that individual stay on the therapy. So in any case, treatments are discussed, options are gone through, a recommendation is made, information is provided. There's a discussion about side effects and how we treat side effects. Then the all-important insurance verification, which maybe should come up here because they basically drive whatever we do. And, of course, what will happen is it'll be the one drug that that person's insurance doesn't cover, so that we now have to jump through 75 hoops in order to get it approved. And then finally, we'll be training to actually have that person begin on the treatment. And then, of course, we have to consider, do we know how the drug is working? And we do lots of close follow-up with MRI sometimes, with how someone is doing clinically. Are they having any relapses? Have they gotten any worse? And a discussion takes place. And if the drug doesn't seem to be working, we make sure that, in fact, it's being taken as prescribed, because recall, human nature says that's pretty hard to do over the long haul. And if it's truly not working, then we're going to change things around. Okay? For people with the disease, they have to have a lot of information and they have to have a lot of knowledge. We believe it's just as important for people to have knowledge about the disease, the therapies, the side effects, and so forth, and then also what are their resources and where can they get help. So these are support lines, and if you, I think these handouts are available and these will be on the website. Okay. And of course, each of the drug companies has this information, of course, on their website. So in conclusion, all these therapies work. They reduce relapses. They have an effect on progression. They change, they can have an effect on what we see on the MRI. People with MS need to be well educated so they understand what the drugs can do and why they're important to be on. And the key is really initiating but adhering to therapy for the long haul. And it really requires good communication. This isn't a dictatorship. Okay, this is truly the democracy where you really have to work with your provider, with your resources to be able to initiate this therapy and to stay on it. And so with that, I think that's